Hello and welcome. Thank you for joining us today. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly privileged to support caregivers and professionals from coast to coast. We focus on relationship-based care built on the foundation of our promise to love and care for your family as we do our own. That promise is what initially drew me to become a member of the Kensington family, as my father lived there for almost 7 years. It is programs such as the one you are attending now that are so important for those of us walking through a caregiver journey to hear from expert professionals on keeping us current with the latest advances in care management and treatment of conditions that affect seniors and their families. The webinar today that I am so excited about examines the connection between menopause and dementia. There has been so much information on that recently. The timing is perfect. It is truly remarkable, the results of current studies. If you're new to the Zoom platform, the presentation is in webinar format. This means your cameras and microphones will remain off and muted throughout the presentation. We will have a live Q&A at the conclusion of the presentations. Each of our attendees today will be receiving a recording of this webinar, along with links to connect you with Kensington and our presenters. Please share this webinar with friends and family. You will be receiving a copy of it in the next couple of days. I am so excited to introduce Eliza Vista. We have gotten to know each other. She runs the programs at Columbia. So please welcome me, Eliza.
Thank you so much, Susan, and thank you all so much for joining us tonight. It is my pleasure to introduce Dr. Susan Loeb-Zeidlin. She's an obstetrician and gynecologist at New York Presbyterian Weill Cornell Medical Center and assistant professor of clinical obstetrics and gynecology at Weill Cornell Medicine. She treats women of all ages from adolescence through menopause. Her goal is to provide complete, personalized women's health care that encompasses all the special health issues women face, including family planning, balancing work and personal life, and the challenges of aging. She is a North American Menopause Society certified menopause practitioner and has developed and is director of the Women's Midlife Center at Weill Cornell. Dr. Loeb, I invite you to join us, and we would love to hear a bit about you.
Thank you so much for that lovely introduction. So yeah, I'd love to share sort of how I got to be director of this menopause center. So I'm a trained obstetrician and gynecologist. I did my residency at Cornell and have been there ever since. So that's a long time. My first practice was doing obstetrics and gynecology, which I love, but when my children were little, it was hard to balance. And so I had the opportunity to give up my obstetrics practice. And for many years, I did just ambulatory gynecology. But when my children were finally launched, I was looking for something more to do. And just before the pandemic came, I applied for a leadership program with the goal, sort of relevant to my own life, of addressing the midlife change in women. And through that, we've developed this midlife center, which has been hugely successful with our patient care and our community outreach. And so I'm thrilled to be here today to share some information about menopause.
Thank you so much, Dr. Loeb. And I would like to invite you to begin your presentation.
Okay, so I'm going to share my screen and talk to you about menopause. So the midlife and menopause, it's a transition. And as we all know, every transition, for some are easy, but for many there are challenges. And so what we like to do is give our patients the opportunity to kind of talk about the challenges and we can address them. So I'm going to give you some information about menopause. There we go. So what is menopause? Menopause is defined by the final menstrual period after a woman goes 12 consecutive months without a period. So in fact, it's a retrospective diagnosis. You have to go 12 months without a period, and then we call you menopausal. It is caused by a decrease in production of hormones, estrogen, progesterone, testosterone from the ovaries. The time leading up to menopause is called perimenopause, during which time the hormones fluctuate, cycles can become irregular, and symptoms start to develop. So the average age of the final menstrual period is about 51 and a half, and a normal range is from about 40 to 58. So why is it so important that we talk about it? As I already mentioned, it is a transition. It can be a time of physical and emotional changes for women, and it's often during a very busy time in a woman's life. As the average life expectancy of women is approaching 80, it's clear that women spend about 40% of their lives or more in menopause. And if you look at the diagram below, so many of our resources are spent in women of reproductive age. And our goal is to help this population of women, which is a huge population of women going through menopause. So how do you know if you're menopausal? Again, generally it's defined by the lack of periods for a year. Sometimes we do lab values, and you can see what happens. This line here is our estrogen level that goes down. But what I don't show you in this diagram is this time period around that final menstrual period. It's not a straight line like that. In fact, the decrease in estrogen is up and down like this. And so that's when a lot of symptoms occur during that fluctuating hormones during that perimenopausal time. So what are the most common symptoms of menopause? Again, that change in menstrual cycle that I already mentioned, that's perimenopause. Of course, any bleeding after menopause needs to be reported to your provider. Hot flashes and night sweats, most common symptom. Vaginal dryness, that happens to get worse as menopause goes on and goes along with painful intercourse, and something we're very able to address. We see urinary symptoms, sleep disturbances, and sometimes mood changes, depression and anxiety, or just mood swings. And other symptoms that we commonly see are relevant for tonight are cognitive concerns. I saw 5 women yesterday who complained about brain fog. So memory, concentration, and just not thinking clearly, we commonly see. And I'll get into that a little bit more. And then some of these other changes are associated with menopause: joint pains, dry eyes, change in our bodies, the weight distribution, cardiovascular disease, palpitations. Definitely we see a bone loss. That's silent. While it might not be symptomatic, it's a really important change during menopause. And some women experience skin and hair changes. And you'll see in big letters here, everybody goes through it differently. So just because my best friend was really suffering, you might not be suffering. There's no one universal menopause experience. So let's talk about the most common symptoms, because they're relevant again to what we're talking about tonight. 60–80% of women have some hot flashes, which includes also night sweats during this transition. They're most common in the first 2 years before menopause and for 1 year after. But in fact, it's been shown that for some women, they can last up to 10 years. Hot flashes and night sweats can have significant impacts on sleep, mood. They've been linked to heart disease, independently linked to heart disease, and definitely linked to difficulty with alertness, concentration, and cognition. So hot flashes alone can cause changes in cognition, but in it, their impact on sleep and mood also can cause those changes. Interesting to note that Black women have the most hot flashes, and they often last longer. So sleep disturbances, again, can be due to hot flashes and night sweats, but there are other causes of sleep disturbances that happen related to the menopause transition. Again, the mood changes, the anxiety, the emotional distress that women are going through can lead to sleep disturbances. Interestingly, apnea. So sleep apnea, where you gasp for breath during your sleep and are woken up by that, increases for women during this menopause transition. So like I just said, how the body changes during menopause, and we see more in the midriff, we also do see more in the neck, and that can increase the risk of sleep apnea, waking up, and again, impact our cognition. Depression and anxiety can definitely increase during this menopause transition. It's especially seen in women if they've had a history of premenopausal depression, including a postpartum depression. Estrogen receptors in the brain are involved with mood regulation. So sometimes if we give estrogen replacement in cognition, in combination with antidepressants, it really can work together, what we say synergistically, to help with depression and anxiety. And then we see these cognitive changes that we talk about. And this is a image of a brain, how we can see that there are sometimes changes that are noted in a woman's brain as they go through menopause. Sometimes we see that that actually improves once they're through the transition. But these are common complaints: difficulty concentrating, brain fog. And we know that female hormones do modulate our brain function. And like as Bertie mentioned, the vasomotor symptoms, which are the hot flashes and the night sweats, sleep disturbances and mood changes also can impact our cognitive function. So what are some treatment options? So the first thing we talk about are lifestyle modifications. We can talk about supplements, medications, some alternative therapies, and I'll go through some of that with us real quickly. So some lifestyle modifications, especially if you're getting hot flashes and night sweats, which I already said is the most common symptom. Trying to lose weight can improve that. And that's also good for other modifiable factors that are happening in our life as we go through menopause. Wearing some breathable clothing and keeping fans around. Caffeine avoidance, alcohol, they can all be triggers for some of these symptoms, as well as spicy foods. Increased physical activity. Sometimes women going through menopause are getting more sedentary. Increased physical activity can help with symptoms, can help with cognition, and is really good for, like I said, some of those other changes that happen during this time of life, including increased risk of hypertension and lipid profile and possible diabetes or insulin resistance. So being more active is really important. Stress management, I talk about that a lot in my office, but mindfulness practices, yoga, meditation, all can really make a difference. They can certainly help sleep, which in fact will help your cognition. They can help your mood. Smoking cessation is important for all things I talked about, including hot flashes and all those other risk factors. And eating well, dietary modifications, fewer carbs. Carbs get harder to digest. Mediterranean diet is a healthy diet, and more plant-based eating. Maybe not being, it's hard to be strictly plant-based, but focusing more on that part of the diet is really healthy. Supplements. So always inform your provider about the supplements you're taking. Not all of them are as benign as you think they are, but some of them that are safe and helpful. Vitamin D can help absorb the calcium for your bone health, which I already said is changing at this time. If you're going through perimenopause and have heavy bleeding, you might want to take an iron supplement. Magnesium may be helpful for sleep, headaches, bone loss. If you are focused on a plant-based diet, zinc might be helpful. And then there's a supplement called black cohosh, which is what we call a phytoestrogen. It's a plant that has estrogenic properties. Now, for a lot of people, for most, it's probably a placebo effect, but nevertheless, a placebo effect is real and can sometimes help the symptoms. All right, hormone therapy. So there's been a lot of press about that recently. So during perimenopause, I like to give a birth control pill for those who are able to without any contraindications. It really helps stabilize the hormones. And in fact, a woman can get pregnant until her final menstrual period. So it also gives that contraceptive benefit that hormone replacement therapy doesn't give. So that's a really nice way to help a woman go through the menopause transition. It'll cover up when that final menstrual period happens, but we don't really care. We just want to help them get through this transition with ease. We'll have to take a woman off by 55, but usually we'll take a woman off a little bit earlier. So what are the FDA approved indications for hormone therapy? The FDA approved indications are for moderate to severe hot flashes or night sweats, for the prevention of osteoporosis for women at risk, for the treatment of vaginal dryness, and for that we would give a local estrogen rather than a systemic, but it may be beneficial for many of the other symptoms, including mood, cognition, sleep, joint pains. That's an interesting one. And also in younger women for their cardiovascular health. So those are off-label uses, but it's a discussion that we have with our patients. People who cannot take hormone therapy are those who've had breast cancer or uterine cancer, usually. Unexplained vaginal bleeding, we have to evaluate that first. A history of blood clots, liver disease, heart disease, including stroke, and also it's not recommended in women who smoke. I have a comment here that a lot of women come in asking for bioidentical hormones. So the commercially available formulations, many of them are biologically identical to the hormones our body produces. But the stuff that's compounded in pharmacies has a lack of regulation. And for that reason, we generally recommend using the commercially available formulations. So who can take hormone therapy? Again, it's definitely recommended to start within the first 10 years of menopause and before age 60. Now, the New York Times did a great article in the February 5th Sunday magazine. And it was the story of hormone therapy from 2002 until the present. Before 2002, women were taking hormone therapy for everything from head to toe. In 2002 came a study that's called the Women's Health Initiative Study that was 30,000 women, but they had to stop the study because they were seeing an increased risk of heart disease, breast cancer, and stroke in women taking hormone therapy. But over these 20 years, since that study was done, it's been reevaluated. So the average age of women in that first cohort was 63. And that's obviously, so, since I told you the average age of women going through menopause is 51 and a half, that is an older age population with other medical problems. And when they looked at women in the first 10 years of menopause and before age 60, the risk profile was very different. And that's where we get the idea that the risk of breast cancer, heart disease, and stroke is much less significant in women in that time period. And that's who it's recommended for. We try to get you off after 5 years, but that's a shared decision making that you make with your provider. This is a QR code to that article. It was really interesting. There are non-hormonal things that we can try. Paxil is an antidepressant that's approved for the treatment of menopausal hot flashes. There are some things that we use off-label, specifically gabapentin, which is also known as Neurontin. It helps with sleep, it helps with hot flashes. And at the bottom of the slide, there's a new drug in the works. So I thought it was going to be approved this month. Looks like they're bringing it to the FDA now in May. But it is a medication that targets the neurons in the brain that actually cause the hot flashes. So it's a non-hormonal treatment for menopausal hot flashes that is in the process of going to the FDA for approval. It's really interesting. There's hypnosis, cognitive behavior therapy, acupuncture have been shown to be helpful. But the lifestyle modifications are super important. Really, that's the first thing we talk about. Healthy eating, healthy exercise, stress management, sleep hygiene, all of that is really important. So just some important takeaways. Again, the average age of menopause is 51 and a half, but symptoms may start before and last after that final menstrual period. The care of a menopausal woman is very individualized, but there are many things one can do to alleviate symptoms, including, as I just said, those lifestyle modifications. Treating some of your menopausal symptoms may improve your cognition, but there's not a conclusive evidence on the role of estrogen in preventing dementia. And again, other modifiable risk factors during midlife can help decrease the risk of dementia. So working on those cardiovascular risk factors can really make a difference. It is so important to discuss all the symptoms you're experiencing with your provider. And as I said, for many people, hormone therapy can be safely used, but for others, there are options that are non-hormonal. So now I think I'm going to turn this back to Elisa, who's going to introduce Stephanie for the next part. That should be really interesting.
Thank you so much, Dr. Loeb. That was wonderful. And our next speaker this evening is Dr. Stephanie Cosentino. She's a graduate of Drexel University and an associate professor of neuropsychology at Columbia University Department of Neurology. Her research has examined the cognitive, behavioral, and metacognitive profiles of various neurodegenerative diseases, particularly Alzheimer's disease and frontotemporal dementia. The overarching goals of her current work are to characterize the factors that explain metacognitive variability along the spectrum of healthy to pathological aging and to identify the practical consequences of metacognitive impairment for everyday decision making and quality of life. It is now my pleasure to introduce Dr. Cosentino.
Hi, thank you so much, Elisa. And thank you all
Thank you. And
for,
we'd love to hear a little bit more about you and the work that you're doing.
yes, absolutely. So I just want to say it's very exciting and it's really an honor to be on the webinar tonight and to present along with Dr. Loeb. So as you all have heard, my background is very different from Dr. Loeb. So I am a neuropsychologist and my training is in understanding brain behavior relationships. I've always been very interested in brain aging. I don't have a specific reason or explanation as to why that is. I can tell you that when I was an undergraduate at Georgetown University, I took my first psychology class and it was taught by a neuropsychologist who was incredibly passionate about his work. And I really became hooked from that moment and have had kind of like a straight shot course to studying brain aging throughout my career, really. And one of the things that I think really has gotten my interest is in understanding self-awareness and how it is that the brain is aware of itself. I find that just something that I could think about for hours. And because of that, I became interested in diseases like Alzheimer's disease, which can really rob people of aspects of their self-awareness and their identity. And so some of the work that I'm doing now is really focused on the subjective experience of memory loss as people age and trying to understand people's perceptions of how their brain is changing and when that's normal and when those changes are not normal. And so that's going to be a lot of what I talk about tonight. And so I'll do the dementia piece of the webinar, and then we can talk a little bit more about the possible connection between menopause and dementia. I am not an expert in menopause. This is a really exciting new area that we're trying to understand and to really move further in studying the female brain in particular. And so this is just really a wonderful kind of opportunity for me at this particular point in time. I'd like to give a shout out to one of the attendees tonight, Jillian Joyce, who is also my research program coordinator, and she has a particular interest in women's health, and she's really been pushing us to understand brain aging in women in particular. So with that, I think I'll share my slides.
Thank you so much, and we look forward to your presentation.
Okay. So I assume you all can see my slides. Please let me know if you can't, but I will just move forward. So I think I have about 15 minutes to cover cognitive aging and dementia, which means I'm going to stay pretty high level and try to touch on the topics that I think are most relevant for tonight's presentation and which people might have the most questions about. So I'm beginning just with the unfortunate fact that as we age, our brains get smaller. And it's sad, but it's true. And I think you can see that here in this figure, if we look over to the left, what we have are people who are in their 30s. And as we move to the right, we have people who are getting increasingly older, with people in their 90s all the way at the right side of the graph. And what we're graphing here is the size of the brain, so total relative brain volume, sort of how healthy, how big our brains are. And on average, essentially, it is the case that as we get older, on average, our brains get smaller. But it's also important to realize that there's a lot of individual variability. So not everyone's brain changes in the same way as they age. And here you have an example of someone who's in their 90s, here someone who's in their 80s, where their brain size is really quite comparable to others who are quite a bit younger. So the take-home point is really that we want to leverage this individual variability that is present because we want to do whatever it is we can during our lives to kind of keep our brain at its optimal level of functioning. So in terms of cognitive functioning, we can think about a number of different categories. So everyone is very familiar with the idea of memory, and memory changes as we age. But of course, we experience changes in other aspects of cognition as well, including language, attention, executive function, which is our ability to plan and multitask and problem solve, and then our ability to navigate our spatial environment. And it's normal to have some degree of change in all of these domains as we age, because cognition depends on the brain. And cognitive complaints are quite common in older adults. So if you were to interview a group of older adults, you would find that the vast majority complain about their memory. And so when I hear someone tell me that their memory is bad, I don't get too concerned. Fewer of these people will actually go so far as to say that their memory is only fair or poor, meaning kind of below the average range. And even fewer will say that their memory is worse than others their same age. So I think what I'd like to just highlight on this slide is that, it may be something you want to talk about to your provider about if you do feel that your memory is truly below average or worse than others the same age. Because there are aspects of our cognitive changes that are normal, but of course there are some cognitive changes that we may want to address and which could be reversible. So another way to think about what is normal versus what is abnormal, excuse me, I'll go back, my mouse detected movement. So here is a group, let's just say an imaginary group of older adults, all of whom have cognitive complaints. Now, some subset of these people have typical aging in their brain, and a smaller subset have some form of atypical aging, which could be Alzheimer's disease or another brain-related illness. And so these are the types of complaints that I consider to be relatively frequent and benign. I misplaced my keys. It's hard to remember names of the new people I meet. It takes me longer to find the word I want to use. It's on the tip of my tongue. It takes a while for it to come to me. I hear these types of complaints a lot, and they're not inconsistent with typical cognitive aging. These complaints here in red are a little bit more concerning. I'm getting lost in familiar places. I'm getting confused by the things that I used to be able to do well, like paying my bills, managing my medications, following recipes. And this type of complaint where you hear someone say that they've lost memory for an event, completely lost memory. So for example, I don't remember visiting my daughter this weekend. And through conversation and cueing, it's not coming back to me. So complete loss of memory for something that would otherwise have been a memorable experience is certainly something we would consider to be out of the norm and a little bit unusual. Now, there are always circumstances that can lead to these kinds of experiences that are not Alzheimer's disease. So if someone is particularly stressed that weekend and there's a lot going on, there can always be reasons that these types of things can happen. So it becomes more about a matter of how frequently is it happening, how much is it impacting your day-to-day life. So we can think about cognitive aging along a spectrum where at the top we have the vast majority of people who will experience typical cognitive aging. A smaller subset of people would actually meet criteria for what we call mild cognitive impairment, or MCI, which is when you're concerned about your memory or someone who knows you well is concerned about your memory. And upon being evaluated, you're found to have significantly impaired performance in comparison to where we would have expected your performance to be. Now, this is a very heterogeneous group. There's a lot of reasons why people can be experiencing MCI. It's not in and of itself a disease, it's a category, right? So it's a level of difficulty that could be explained by a number of different factors. One such thing that's reversible could be a vitamin deficiency, for example. However, there is a subset within this group who will progress to develop a dementia. So MCI can be the earliest clinical manifestation of diseases like Alzheimer's disease. So let's talk about dementia and what dementia is. One of the most common questions I get is, what is the difference between dementia and Alzheimer's disease? And so this is a nice graphic, which I think helps to clarify what the relationship is between dementia and Alzheimer's disease. So we often talk about dementia as an umbrella term, which is used to describe a collection of brain diseases and their symptoms, which can include memory loss, impaired judgment, personality changes. And the key here really in something being meeting criteria for dementia is that these difficulties are severe enough to impact your ability to perform your normal day-to-day functions. And that's really what takes something from a diagnosis of mild cognitive impairment to dementia, this inability to perform at the level where you used to perform. Now, these are different neurodegenerative diseases under the umbrella: Alzheimer's disease, vascular dementia, frontotemporal dementia, Lewy body dementia, and another number of others here, all of which can cause dementia. So these are the brain diseases that ultimately result in cognitive difficulties and impairment in everyday function. I think the reason Alzheimer's disease and dementia get confused so frequently is that Alzheimer's disease accounts for the vast majority of dementia cases. So most people who are diagnosed with dementia in late life have Alzheimer's disease. And Alzheimer's disease is characterized by specific types of brain changes. You've probably heard about amyloid plaques and tangles. And one of the hallmark signs of Alzheimer's disease is difficulty in memory. But of course, you can have difficulties in a number of other areas as well. What are the risk factors for Alzheimer's disease and other dementias? There are many, many studies, epidemiological studies and observational longitudinal studies have tried to answer this question. Many geneticists are trying to identify the genetic contributors to Alzheimer's disease. And at the current point in time, I think there is an appreciation that it is a complex set of causes that lead to Alzheimer's disease. And those causes include both genetic influences that have effects on the brain through these different pathways, as well as a number of different exposures throughout our lifetime. And I really like this figure, and it's taken from this article in Lancet Neurology, because I think it breaks down in an easy to understand way the different exposures that happen at different times in our life that increase our risk. I do want to make the point that these studies are not identifying causes as much as they're identifying associations. So, for example, the presence of smoking or obesity in midlife is associated with an increased risk for Alzheimer's disease. We don't know that that's causing the disease, but it's an important and modifiable risk factor that we can address. So, of course, tonight we're talking about women and the possible link between menopause and dementia. And I think part of the reason that this potential link is getting a lot of attention right now is that it's become clear that women have an increased risk for Alzheimer's disease as compared to men. It used to be that we believed that could be based on the fact that women live longer, but people are in agreement, I think, at this point that really that is not what underlies the increased risk in women. And so here you can see a few different graphics taken from the Alzheimer's Association Facts and Figures report. Here in the middle, we have a bar graph where women are represented in purple, men are represented in yellow, and these are two different age points, right? So at age 45 and at age 65, what we see is that women have about double the estimated lifetime risk of developing Alzheimer's disease as compared to men. And just some other statistics here in the United States, more than 10 million women are either living with Alzheimer's or caring for someone who has it. And almost 2/3 of Americans living with Alzheimer's disease are women. So this increased risk has led a lot of researchers to think about what is unique to women that could be elevating their risk. And I am certainly not an expert in this area, but my understanding is that there's a growing amount of studies Some of them are listed down here, which are starting to examine different menopause and reproductive experiences, characteristics, and how they may increase risk or resilience to Alzheimer's disease for women. Some of the things that are under study are the history of hormonal contraceptive use, hormonal replacement therapy, number of pregnancies, age at menopause, type of menopause, all really with a focus on what the potential role is in hormonal changes that women experience during menopause for elevating risk for Alzheimer's disease. And what I can say, which is a very positive thing, is that I am sensing an increased focus in the field, both from scientists and from funding agencies, on this connection between menopause and dementia and on women's health in general. There is a recent call for applications from the Alzheimer's Association to specifically examine sex and gender in Alzheimer's disease. And there's this Trans Institute initiative through NIH to really advance science specifically related to women's health. And so I'm just going to finish by talking a little bit about some ways that we can think about trying to lower our risk for dementia. And it's a lot of the same things we just heard Dr. Loeb talking about in terms of kind of improving health during menopause and after menopause. And an easy motto is what's good for the heart is good for the brain. So these are the American Heart Association's Life Simple 7: stop smoking, eat better, get active, lose weight, manage your blood pressure, control cholesterol, reduce blood sugar. These are all things that we are familiar with as being good for your heart, but the truth is whatever is good for your heart is good for your brain too. And these are another sort of way to break down or think about the ways that we can help reduce our risk for Alzheimer's disease or love your brain. And these are on the Alzheimer's Association website, which I will share with you in just a moment. A lot of the tips here overlap with what we've heard about and talked about so far as being things like exercise and diet, which are good for your overall physical health. But I think it's important to point out that there are some other things too that research has identified as being potentially useful to kind of increase your resistance or resilience to Alzheimer's disease. And one is to hit the books. So formal education in any stage of life seems to reduce risk of cognitive decline. Similarly, stump yourself, challenge and activate your mind in whatever way you enjoy. I think something that I take from most of the literature is that being mentally engaged, whether it's through something like a crossword puzzle, whether it's through staying socially engaged with friends, pretty more often than not is associated with a positive cognitive outcome. So these are just a number of resources that I wanted to provide because of course I can't really touch on everything that is important to know. I'm sure I have not answered all of your questions, but I will give a plug to a book I've been reading to learn more about the possible connection between menopause and dementia. It is The XX Brain by Dr. Lisa Mosconi. I have it right here full of sticky notes. Dr. Mosconi is the director of the Women's Brain Initiative, I believe works with Dr. Loeb. And I would encourage you to take a look at that book if you're particularly interested in the research linking estrogen and brain changes in later life. So thank you.
Thank you so much. And I just want to encourage the audience to share some questions that you have in our Q&A. It's at the bottom of the screen. It says Q&A, actually is exactly what it says. And I want to applaud that you put on there, get involved in the research, the Brain Health Registry and the other things, because the more you know, the better off it is. And the more that we can help research moving forward, the better we're all going to be. Susan, can you join us again, please?
Yeah.
We need to get going before I go from Mary Poppins to Cruella de Vil and some of our audience as well. I actually love that because that's exactly why I did go on hormonal replacement therapy. Is My kids were so old that when I saw them and they were at the house, I didn't want to be Cruella de Vil. So I also love what you said, although it's a little scary that 40% of our life is in menopause. That means we're kind of in a jumpy house, that you explained that the hormones kind of go like this. And that's exactly what it reminds me of, all the balls up in the air, dropping at different speeds. And one last thing that I want the audience to think about is that you said estrogen is a modifiable risk factor. I love that. I'd never heard that before. And I just think that's really good to know that, it's available. And Stephanie, I had never seen such a great chart on dementia as the umbrella and the different diseases underneath. And I never knew that Alzheimer's, gains a 60 to 70% of all dementias. I mean, that's just scary. I know you guys are all working on something that we can do for some type of an antidote or a cure, but I love the fact that we're all sharing about what our modifiable risk factors are. I think that's wonderful. I'm going to go ahead and start with the questions that were submitted at registration, and now our Q&A is quite active. So let's get going to it. Does it matter, Susan? We'll start with Susan on this. Does it matter at what age you go through menopause? And can the age be a hereditary link? So in other words, if my mom had an early menopause, or if my, my family lineage went through menopause at a certain age, can it be a little bit of a hereditary?
It definitely does run in families. So we often ask women going through it or starting to go through it when your mother went through it. So definitely it's not perfect, but there is a hereditary component. So what we do know, so as I mentioned, early menopause is menopause that happens before age 45, and premature menopause is before age 40. And both of those ages, if menopause happens, especially if it happens because of surgical menopause, which means you have surgery for one reason or another to remove the ovaries, that can be a risk both for, as Stephanie was saying, heart disease and possibly for dementia. So in those women, both for those increased risks, it might make sense to give the hormone therapy to replace the hormones that the ovaries aren't producing anymore.
And is there, how long can women stay on HRT? This is from Molly. And, what factors determine staying on longer or not?
It's a great question. So, as I said, it's a very much a shared decision a decision that you make with your provider. But after 5 years, we do see a slight increased risk of breast cancer. And after age 60, and especially at 65, we definitely see an increased risk of heart disease. So, but some women really feel so much better with their hormones that these are not risks that are so huge that a woman absolutely has to come off. But what I do with my patients is we try, and we gradually will wean down and get to the point that they are comfortable. Most women, it's not like your hot flashes come back with a vengeance for most women after they've weaned off of it after 5 years. So for most women, we can get you off, but for some, we'll continue.
I've also heard that take a little vacation from it and see how you feel, and then kind of make the decision.
Well, that's why we wean. So we try to wean. So, yeah. So that's
it's not just stopping immediately. And Stephanie, we've had a lot of questions come in about genetics and Alzheimer's. If my dad has it, I had an increased risk. Dina asked, and Margaret also asked if my father suffered from dementia. Is it hereditary?
So we know that there is some increase in risk with a family history of neurodegenerative disease. I want to emphasize that it is not a sure thing, right? That if one of your parents has dementia, it is not, especially in the context of Alzheimer's disease, like the vast majority of cases, 99% of cases are not truly familial in the way we think of a familial disease where a child has a 50% chance of inheriting that gene. That is not the kind of disease Alzheimer's is. So there is somewhat of an elevated risk. ApoE is a gene that has been associated with increased risk for Alzheimer's disease. So if you inherit that gene, again, you may have an elevated risk, but that's always balanced with all of those other factors that I was showing on that slide. There are a lot of lifestyle factors that lower or increase risk, and there are probably other protective genes that we still don't know about. And so, yes, there is somewhat of an elevated risk, but it is not a certainty. I just wanted to emphasize that.
So it's a factor like the other things that we talked about. There's just so many factors that are kind of
Right, exactly.
And Susan, I'll begin with you on this. Does having a hysterectomy affect likelihood of developing dementia? But I'm also going to ask you, what is a chemical hysterectomy?
I don't know what a chemical hysterectomy is.
There was 3 different types. Maybe I'm not using the right word. There was
Okay. There's natural menopause that you gradually lose your hormones. There's surgical menopause where we take out the ovaries, and then the third one is maybe due to chemotherapy or something. An induced menopause. I think that's what you're referring to. So sometimes a young woman who has chemo might actually become menopausal. Sometimes they don't. So good question, because logically you think if hysterectomy is just removal of the ovaries by removal of the uterus. That's by definition. So logically, you think that wouldn't cause any hormonal changes, but there are some studies that show early onset dementia in women under 50 who do have a hysterectomy. Now, again, that's showing a relative risk of something that's really not likely to happen anyway. So the chance of that is super small. But if they do take out the ovaries, if you need to have your ovaries removed, especially like I already mentioned at that younger age of 40 or even 45, younger than that, then there seems to be an increased risk of dementia. And for those who are able to, hormone therapy might be beneficial in that population.
Good. Thank you. Thank you so much for that. And what are some, well, I think we kind of covered this. What are some proactive ways to protect your brain in pre and perimenopause? And I just want to remind the audience that you will all be receiving a copy of this to share with friends and family, so you can look at the beautiful presentations that both Susan and Stephanie prepared. And I think a lot of these were answered in there, although this, I don't think we did. I read flu vaccines can be tied to lower dementia risk. Is there any truth to this? You want to start, Stephanie?
Sure. So I took the liberty of looking into this today, since we had the questions submitted in advance, and this is something I'm not, familiar with. So I did come across several studies pointing to a reduced risk of dementia, including Alzheimer's disease, following a flu vaccine. It seems like the reasoning is that preventing or attenuating an inflammation-related immune response could delay or reduce risk. So there was a recent study in 2023 that looked at a representative sample of adults over 65 without cognitive impairment, and they found that those people who were vaccinated were 40% less likely to develop Alzheimer's disease than non-vaccinated peers over the following 4 years. Now, there are a lot of things that could explain that finding. And so it's just always really important to think about that when you hear these kind of headlines, right, in the newspapers and on the Today Show and wherever. These are association studies, and you always have to think about what are the other factors that could be related to A, deciding to get the vaccine, and B, getting or not getting Alzheimer's disease. And so just a few examples of the types of factors that could link those things that were not looked at in the studies were someone's access to healthcare, someone's educational background, someone's level of social support. So these are all kinds of things that could explain that reduction in risk. So yes, it's been reported. Is it causal? No. Your guess is as good as mine.
You said before about you were so amazed at the brain and how self-aware the brain is. And it reminds me of seeing a shooting star and imagining that happened 2 million years ago and how vast the universe is. And I actually witnessed that, destruction of self-awareness with my father when he had Alzheimer's. This is for you, Susan. Do you offer topical progesterone to help with vaginal dryness applied to the thigh?
That's testosterone, and that's I'm going to just
Oh.
say that that's very individualized. You know, there are risks associated with testosterone use, but if hormone therapy is not doing the trick, there are situations where we use it. Definitely give about 1/10 the dose that you give to men. So again, it's very individualized. I don't do it often, but there are situations where people need it.
Yes, and I will say that we've gotten a lot of good response from the audience. They're so thankful for this incredible information that you've shared today. But I'll ask Stephanie another question. If I don't have Alzheimer's by age 65, am I not likely to get it? Like, am I out of the woods?
I wish I could say yes, but I can't say yes. No. Yeah, I think what we know is that the prevalence of Alzheimer's disease really gets more and more frequent, actually, after the age of 65. So in being 65 without Alzheimer's disease, I can't say, but at age 75 or 85 that someone wouldn't develop it.
I wish it was a clean number like that.
Yeah.
It would make life so much easier not to worry. There's one question that came in that I really wanted to address, and that was, why isn't there standards or laws on how senior citizens are treated? I understand other countries have standards. And I was actually super lucky to do a webinar with Adult Protective Services. And I will just share with the audience, I am so impressed with the resources that they offer to everyone. Anyone can call Adult Protective Services, and it's not like calling the police. They come, they offer care, support, and resources for the home. So I encourage anyone that is concerned about the treatment of anyone adult in our community that you contact them, and they're available no matter where you live in whatever city you live in. One last question. Thoughts on lecanemab? I probably mispronounced that. I'm sorry.
No, you didn't. Yeah, so this was another thing that I tried to kind of look into a little bit more maybe than I otherwise would have. I'm not a physician. I want to make that very clear. I don't see patients or prescribe this drug. My sense of the pulse of the field is that there's a lot of excitement and optimism from many people, and then there's also some kind of concerns by others. You know, if there's some cool videos on the Alzheimer's Association website, and today I watched a conversation about this drug, and you know, they were describing it really as a profound shift in treatment options for Alzheimer's disease, which I think most people would agree with. This is really the first drug that's getting at the underlying biology of the disease and modifying that biology. And in clinical trials, it did show that it could reduce the level of one of the main biology or you know, abnormal proteins in the brain of patients with Alzheimer's disease. And that reduction was associated with a slower decline over 18 months. So you can't really argue with either of those things as being positive. On the other hand, I think many people in the field feel that the disease is far more complex than that single biology, and that there is a lot still to learn, and there are some concerning side effects with the drug, and it's incredibly expensive. So I think that there is kind of like an optimism, but just tempered with some of the realities of it's progress. It's certainly not a cure.
I'm glad we're making progress, though. And Susan, I'm going to end with one question to you, and that is, does omeprazole, okay, maybe you can tell us what that is, since I don't know what it is, speed the onset of dementia?
That's a proton pump inhibitor, which is used to prevent reflux and for, you know, for GI symptoms, upper GI symptoms. And so it's like Stephanie was saying, There were some studies that showed an association, but again, it's more complicated than that because dementia is such a multifactorial problem. People who have stomach ulcers also have a lot of stress, and so could it be the stress that's causing the dementia or something else? So it's not a direct link. It's not. There are some studies that show an association, but there also might be other drugs that women are taking that could interact with omeprazole that could cause cognitive changes too. So it's more complicated than a direct association.
Well, thank you, everyone on the East Coast. Have a wonderful evening. On the West Coast, stay dry.
And remember just to eat well, exercise, avoid too much alcohol. And those are all things that we can do to stay healthy, going through menopause, cardiac health, and brain health.
And play chess. Someone did ask if I play chess, will that help? And I think that was in the mind games that Stephanie shared with us. Thank you, everybody. Have a wonderful evening. And thank you for joining us. Be safe.